Good evening to everyone who's in the room tonight. We really appreciate your presence, especially on a day like this when our national soccer team is playing its second match at the World Cup, as you know, and they are competing with us because Thursday evenings at 18 hours East Clinix webinar time. I mean, that has been traditional for the last 5 years. I mean, we started in 2020, and we've been going on like this since COVID days. And I think we only continue as Clinix to continue hosting these webinars simply because of your interest and your continued participation in these webinars. Thank you very much for this. These webinars, for those who are new, because we always get new ones, so I will start with the house rules that we normally run with. These webinars have been run and sponsored by Clinix Health Group. Clinix Health Group is it's a company that runs 8 private hospitals in the country. The directors, we are thankful to the directors and the executive of Clinix for continuing to sponsor these the weekly webinars free of charge, so that we can they sponsor them so that we can give them free of charge, unlike other webinars that are there in the market. We are thankful for all the presenters who have, on a weekly basis, gave of their time to prepare for these presentations, to share their expertise with colleagues nationwide, by the way, in the interest of maintaining quality healthcare for our patients. And we really appreciate our speakers, but we also appreciate yourselves for being here, especially on a tough day like this one. So we will be as short as possible, and we will allow our speaker tonight, who I'm going to take Tole about in a minute, to speak. And whilst he presents, I think everyone else will be muted. And at the end of his presentation, there'll be a question and answer session, during which you can raise your electronic hand, and if you want to make a comment orally or ask a question orally, you'll be able to do that. Whilst the presentation continues, you'll also be able to put in the chat box. You can write your questions or answers, or questions or comments there, and the speaker will attend to them as soon as we're done. The speaker said he'll be as quick as possible, so that maybe you can watch the match towards the end if we're lucky. Depends on the number of questions. But our speaker tonight is none other than Dr. Thakadu Arnold Mamashela. Dr. Mamashela is a registered and practicing specialist forensic pathologist, who is also head of forensic pathology services in Limpopo Department of Health, and a senior lecturer at the University of Limpopo. Dr. Mamashela is also chairperson of the Ministerial Advisory Committee on the committee is called the National Forensic Pathology Services Committee. It's one of the committees that advises the minister on these specialized matters in forensic pathology. But he is also he is also fellow and a council member of the colleges of forensic pathologists at the Colleges of Medicine of South Africa, and a member of the Medical and Dental Board of the Health Professions Council. You know that the HPCSA has got 12 boards, the biggest one, of course, being the Medical and Dental Board. He's passionate. I know that he's passionate about administrative aspects of forensic pathology services, and he has set himself to to improve multi-stakeholder involvement and also engagement at different levels to ensure that there is quality medical legal investigation of death. It's a topic that affects all clinical disciplines in medicine, in healthcare services as well. And I think it's a topic that needs to be shared with us on a regular basis, especially with new doctors coming on stream year after year, but also with the doctors who've long been qualified. I think there's always a lot to learn when we talk about death notification and death notification and death certification in South Africa, notification and certification in South Africa. So I think the topic tonight is a good one. Dr. Mamashela, I'll hand over to you now, and I'll just mute whilst you go on, and then I'll come in at the end of your presentation. All the best, Doc.
Thank you very much, Dr. Kinoshi, for the introduction and the warm welcome. And good evening to all colleagues who are on the platform. And I think rightfully so, Dr. Kinoshi has indicated that we are competing with one of the main national events the national team is playing. But we'll try by all means to see how best can you manage to get or catch the second half of the match. But I think it's important from what Dr. Kinoshi has just mentioned, because the topic itself is a topic that most people, whether it's practitioners or ordinary members of society, we tend to shy away from talking about death in general. And it's something that, unfortunately, it's part of our lives. We cannot run or shy away from it, particularly as healthcare practitioners or healthcare professionals, because it's something that happens almost daily. And I think what is important, what Dr. Kinoshi has just mentioned, is that just to have a refresher, because I always call this topic a refresher, colleagues, to say that we'll embark on a refresher course of this nature using this topic, because one of the disadvantages is that when you look at medical practitioners in terms of training from the medical school particularly, and I think most colleagues will attest to that, in particularly senior colleagues, but even the junior colleagues, in terms of the time that we afford students in the medical training to go through forensic medicine, particularly, where a topic of this nature would ordinarily be emphasized, and simply because of the allocation of times and priorities when it comes to a module particularly. And hence, as a result, you tend to be facing these medical legal or potential medical legal issues that are relating to death certification and completion of death notification form when you are an intern or when you are a ComServe in one of the deep rural or district hospitals of this country, and you need to now see how to assist. And that's where you get confronted by this. So I'm going to take you through some of the intricacies and some of the implications. I'll just highlight a couple of them, and because of time, I could not go into much of them, but I'm going to take you through some of them, the topics that are relating to this, particularly some definitions and some legislations that are actually governing or guiding our practice, because in South Africa, our practice is guided by the laws of this country, and we need to observe and follow the laws of this country in terms of what does the law say when you have a death of a patient, for an example. Everything that you do, your decisions are actually guided by the law. Your decisions to proceed in a particular manner when you have lost a patient or your patient are guided by the laws of this country, and we need to observe that. So I'll take you through those pertinent laws, and I'll also take you through some of the pertinent definitions and maybe some few case examples here and there, so that you can also try and put yourself in the shoes of some of the practitioners or some of the adverse events that might have happened. But the purpose is to try and make sure that we avoid some of these implications. And so that's I've been introduced. I always like this quote by Zig Ziglar, because it is a reality that there's never been a doctor who served many patients who, despite their best efforts, did not lose some of them to death. But they understood that was part of life itself. And hence I said that death is part and parcel of our life. As ordinary members of society, it does happen, but particularly for us as practitioners. I know it talks about there's never been a doctor, but it applies to all of us as healthcare professionals, nursing staff, the support staff that are normally involved in treatment of a particular patient. So it affects us, but we tend to understand that it's part of life. But I think it's something that when I take you through, as much as we understand this was part of life, or is part of life, there are implications when someone dies ordinarily, and a series of implications that I'll demonstrate and show you. I'm going to take you through this. This is my presentation layout, and like I've indicated, the definition. I'm also going to touch on procedure-related deaths and who actually completes death notification form, and the purpose. Why must we complete this form in the Republic of South Africa? And some of the mistakes and some of the implications thereof. Now, I'm going to take you through these important definitions, but again, I'm just going to refresh your memories, most of you, because this is something that we get taught mostly in the fourth year level when you are a medical student. Obviously, depending on the institution or the university, but most of the time you would have been lectured then. Then fast forward, you are in practice, you are a registered practitioner, and you have to treat patients. But it's very important for us observe these important definitions, because when a patient dies, there's always this question which applies, across what was the cause of death, and it tends to be what is the important part is the cause of death. We tend to say cause of death, but sometimes, or in most cases, we don't understand what the cause of death means. And that is where a lot of issues arise, because once we don't get it right in terms of how do we define an underlying cause as a disease or what started it all, that's where a lot of things that will follow will then go wrong if we don't get it right from there. Because once you identify the primary event or the underlying cause or what started it all, it then provides you with guidance as a team or as a practitioner in terms of what is the next step. So the underlying cause in simple terms is what started it all. That is a disease or an injury that will initiate a cascade of events, but of importance. These events, they may be brief or they may be prolonged. And again, this is where most of the issues will arise. Now, the implications of not observing this can be dire for all of us as practitioners, but of importance, it will be dire for the family members, because I always say when your patient dies, your responsibility does not cease there. You are still responsible for particularly the family members, because these are the people that must be assisted with a series of processes. So your responsibility still remains as a practitioner, a healthcare practitioner. Now, when I say this can be brief or prolonged, it's simply because we know that diseases or injuries, they can lead to someone to be in the hospital for a day, for a week, for months, even for after a year, even after discharge or so, you still have a cascade of events that are unfolding from the primary event. That is what started it all, either as a disease or an injury. And I'll give an example of that I gave as COVID-19 infection, for an example. You have patients that you have treated, but they suffered long-term complications of the primary infection. You will have someone who's shot, recovers, but because of the complications relating to the injury or the trauma, they live for months, but they ultimately succumb to that. So it's important for us not to lose track of events. Because as much as a person who has been involved in a road traffic crash sustains head injury, stays in the hospital for months with a head injury, and subsequently acquires hospital-acquired pneumonia or a nosocomial infection of whatever sort, and they subsequently succumb to that. You must never lose track of events of what brought this patient to a healthcare facility or to a hospital. It does happen that they may recover, they may suffer, for an example, decipitous bed ulcers that get septic, and they're treated at home as well, and they're treated at the clinic, but they're severe enough that ultimately they succumb to a septicemia or a septic shock that arose from sepsis from the wounds because of prolonged immobilization, for an example. But what started that is that road traffic accident that resulted in the head trauma or head injury. So it's very important, and I'm deliberately spending time on this because this is one of the most important part. If we lose it from there, that's where a lot of things go wrong. You then have what we call an immediate cause, and this is the final disease or injury and complication directly causing the death, but it is resulting from the underlying cause. So the underlying cause will remain, but you'll have this patient who dies of hypovolemic shock. And hypovolemic shock can arise from any condition, natural condition or unnatural condition, which I'm still going to define it for you so that you also have a better understanding, or you better refreshed to say what is a natural, what is an unnatural. Because hypovolemic shock can arise, for an example, from that gunshot wound to the chest. Someone may suffer that hypovolemic shock because of the extent of the injuries, but also if someone suffers a severe gastroenteritis from whatever infective processes to the GIT, they may ultimately succumb to a hypovolemic shock. And obviously, there are so many other examples that we can use. Now, the immediate cause and the underlying cause, we need to differentiate between the two, because the immediate cause is exactly what ultimately the patient succumbed to at that point in time or after those few days or so. But the underlying cause is that what started a sequence of events, which I will then take you through to the next slide when I talk about mechanism of death. There must be a clear definition between the two. You then have what we call contributory conditions, which are other significant conditions that contributed to the death but were not part of the direct sequence. For an example, someone with underlying comorbidities, diabetes mellitus, hypertension, and other chronic conditions, which may have not directly led to the underlying cause, but they do contribute to that. You'll have someone who suffers a myocardial infection from a coronary artery disease, for an example. Now, when you have that person with chronic diabetes, chronic hypertension, and all that, these can only become significant conditions that actually contributed to that. I just gave that as an example as well. Now, when it comes to mechanism of death, now this is where you find physiological or biochemical derangements that are ordinarily incompatible with life. And again, this will be brief or prolonged. Now, this is what will ordinarily happen between your underlying cause and your immediate cause, because this is where the primary event then leads to a sequence of events. And I've put this image for you here to appreciate when you talk about system failure. When you normally say multi-organ failure of some sort, it arises from a primary event that leads to a series of these biochemical derangements, such as severe acidosis, metabolic failure, but this would have ordinarily resulted from a primary traumatic event, for an example, a primary disease process, for an example, that leads to a development of a wide variety of this. That's why when you have a patient in the hospital and you run array of tests, for an example, you'll find a lot of derangements because of that primary, for an example, infectious process that leads to a systemic failure from either a septicemia type of a picture that leads to a multi-system failure. Now, these are derangements that you must observe, that yes, you may have all this, but the primary event or the underlying cause or what started it all must remain that primary or the primary injury. And the immediate cause will be the ultimate condition that would have killed the patient, but what started it all, and in between, you will have this. Now, that is the mechanism of death. It is different from the cause of death, and it is important for me to mention that, to say that mechanism of death does not qualify to be a cause of death when you certify a patient. Mechanism of death arises from an underlying cause. That is the main thing that must be captured accordingly. Now, there is now what we call man of death. Man of death is simply the circumstances in which the cause of death is brought about. Now, you're talking about circumstances which can be natural. And when you talk about natural, you're talking about disease processes. And these are natural disease processes such as your infectious disease processes, your metabolic disease processes, for an example. These are natural disease processes that were not brought about by any other factor, which is an external factor. But you then have unnatural causes. Now, this is where you've got external factors that are at play here. You've got external factors whereby they may be physical in nature, they may be chemical in nature as well. Physical in nature, I'm talking about trauma. Trauma, like I've mentioned an example of a road traffic fatality, someone sustaining trauma to the head from an accident. But you can also have someone sustaining trauma to the head from an assault, which is homicide in nature. Someone decides to pick up a brick and throws at someone's head or someone's chest. The person sustains severe injuries and they ultimately succumb to that. That is an external factor. It's not a disease or a natural process. So it's an external factor. You also have a situation where someone decides, for an example, to intentionally end their lives by either taking an overdose of drugs, drinking another form of a chemical, or even taking a ligature and apply it around the neck, and they hang themselves. And you also have someone who takes a firearm and decides to shoot themselves. So these are unnatural processes. And the definition of these unnatural processes, the legal definition as well, from our National Health Act that I will take you through as we proceed to the next slide. You also have this category of undetermined. And ordinarily, this is for us as forensic pathologists to come up with such. After a thorough investigation that we would have conducted an autopsy in a forensic pathology setting when the death is being investigated by the police, after running an array of tests, and we do not find anything grossly from the post-mortem examination, we do not find anything from the microscopic examination, that is the histology under the microscope, examining all vital structures and other tissues that we may deem necessary. Also, after running a toxicology analysis to rule out the role of toxins or chemicals, when all is negative and the circumstances are also not suggestive of such, we may classify that death as undetermined. However, there must be a demonstration of exclusion of a wide variety of conditions, including from the examination, from the history. It's very important as well for us as well, and examination as well. So there is that category that is undetermined. Now, the unnatural deaths, like I've given an example, they are due to physical or chemical influence, and they may be direct or indirect or related complications of that. So you may immediately throw a brick at somebody, and unfortunately, because the injury is severe enough, immediately the person dies. But it can be from related complications. They may sustain a subdural hemorrhage or subdural hematoma, that they are subjected to a neurosurgical procedure for intervention, and then they ultimately succumb weeks and months after that from the related complications. You will see in the bracket there, I would say this would by definition include procedure and anesthetic-related deaths, as by nature they involve physical and chemical influences. And I'm going to touch on this procedure-related deaths because when we talk about physical and chemical influences, when you take a patient to for surgery or surgical intervention, and unfortunately, a mishap happens there. Either you sever a major vessel, that's a physical in nature, or the chemical influences from the anesthetic agents. That is something that is not classified as natural. And I'm just giving that as an example. We'll talk about it when we go to procedure-related deaths. Now, there's a category that is sudden, and it's called sudden unexpected death. Now, this is someone who's previously healthy, no medical history, no comorbidities, and the person just drops and dies. Sudden and unexpected, or sudden and unexplained, if I may say. Now, this is from the regulation. The definition up there is from the National Health Act. Now, the sudden unexpected death, the regulations that are generated from the National Health Act, they are also governing us to say that the sudden unexpected deaths are not classified as natural because they have to be investigated. As much as the person drops and dies, it may be from a natural disease process that was undiagnosed and that has been there, or that may have just been sudden, or it may be someone who has a chemical influence that was not known, and someone was on particular drugs. I'm just giving that as an example, and it was not known, but this person was with all of us, and as they walk out, they drop and die. So there's no medical history. These deaths are also investigated and are classified under natural deaths until that investigation unfolds and confirmation is made to say it is from natural causes. Now, this is just the accidents that I spoke about to say an accident is normally when an injury or poisoning causes the death, and there is little or no evidence that the injury or poisoning occurred with an intent to harm or cause death. You have a lot of children who will accidentally see, for an example, paraffin, kerosene, and take it in a transparent bottle, for an example. That used to be a problem. It's probably still a problem in certain areas of our communities, whereby a child just drinks that because they think it's water, but unfortunately, there's a chemical influence, or they even pick medication and they think maybe these are sweets, then they start ingesting that, or what recently, I think last year, you will recall we lost a lot of children actually, and we're still losing a lot of children from organophosphate poison in the table force. If you recall, the 6 Naledi children who died, and that made us to realize there's a problem, and which, when we investigated further, we realized that it's beyond those 6 Naledi children, because most of the provinces were affected. These are accidental in nature, however, obviously investigation will tell something else, but those children, they might have picked up something and ate or bought and ate, but the classification as well will also depend on the ultimate uh, investigation processes, the findings there. Now, in the essence, the fatal outcome is called unintentional. So these are unintentional, just like your road traffic fatalities. You drive out of your house or out of your home, and unfortunately, there's a child crossing along the street, and children, they play, they're erratic, they may not have not realized, and unfortunately, you hit the child, and the child dies. Those are accidents, or the child goes into the swimming pool and they drown in the swimming pool. Those are accidental deaths, and they must be investigated. They are not certified as natural. They are not disease processes. Now, suicide, I always use this chap here who's planning to have this tree to grow and ultimately commit suicide when the tree is actually big and strong enough, because it's an injury or poison as a result of an intentional or self-inflicted act committed to do self-harm or cause death of oneself. Someone takes a firearm and they decide to put it on their head and they shoot themselves for whatever reason, and they die. They go and ingest pills intentional. It's a matter of self-injury or self-inflicted here. Now, homicide is when the death results from a violational act committed by another person to cause fear, harm, or death. And this is an intentional act. I deliberately pick up a dagger or a sword, or I pick up a firearm and I shoot somebody directly. Now, that is intentional. It's classified as homicide, and it is also investigated by South African Police Services, and it must not be certified as natural. Now, having said that, with those definitions, because that's exactly what I wanted us to make sure that we understand, because a lot of adverse events, they arise from loss of track or lack of understanding or forgetting those definitions, which is why I said those definitions are very important for all of us to keep in mind on a day-to-day practice, because it is then when you are able to describe or define, and you will be able to classify, and you will be able to then make a decision to say what next. Now, in our country, we work, or our work is guided by the laws basically in this country. And I'm going to take you through to about 4, if not 5, critical laws. I did not include all the laws here, but the ones that are relevant for your decision making in terms of how do you then certify or decide to classify a death. And these are the 4 main. I've already spoke about the National Health Act, but I'll touch on these 3: Death and Death Registration Act, Inquest Act, and the Section 48 of HPCSA Amendment Act. Now, in South Africa, the laws are quite clear that when you're born, you must be registered. It's a law. It's not a wish or a hope of somebody. It's a law of this country, and there's a reason why. It also says when you die, you must also be registered. That is the fundamental issue with this Act of Death and Death Registration Act. It simply says to you as a practitioner, if you are a practitioner and you have treated a patient and you have a reason to believe, or you are satisfied that the death of your patient that you were treating as a primary practitioner is due to natural processes or natural disease processes, the law says to you, you have to certify that death as natural and complete the death notification form, that is the DHA 1663, to that effect. But secondly, it says, if you were not the primary practitioner of that patient, but you are satisfied from the available information in form of the clinical records, the information that you take from history from the family members, and also the external examination of the body. If you are satisfied that all the facts are pointing towards the natural disease process and you are ruling the unnatural death, as I have explained, the law says you go ahead and certify that death and complete the death notification form to that effect that the death is due to natural disease process or natural causes. Now, it further then goes and says, if you as a medical practitioner, you are not satisfied or you have a reason to believe that the death of a patient or another person is not due to natural causes, it then says you have a duty, because it then says follow this next act, that is the Inquest Act. It says follow the Inquest Act. And the Inquest Act, it simply says anybody, whether you are a medical practitioner or you are a member of the public or you are a family member, if you have a reason to believe that the death of another person is due to unnatural causes, it says you are duty bound to report to South African Police Services, so that South African Police Services can start the investigation process from what you are reporting for that decision to be made. Because you are saying that this person did not die of natural causes. We suspect that this person was given a substance, and we suspect that this substance is 1, 2, 3, 4, 5. Or this person was involved in an accident 3 months ago and died at home, and we have a reason to believe that the accident or the road traffic crash actually led to the demise or the death of a family member or a patient. The Inquest Act says you have to go and report. National Health Act, I've already touched on it to talk about the definition of what is unnatural death. Now, Section 48, I'm going to touch on it towards the end. I mean, when I go to the procedure-related deaths, because they're actually, I want to take you through what used to be there and what is currently in place, because some practitioners may not have an idea of what does this act actually says. So I'll project it. Now, this is the Birth and Death Registration Act. As I have said, the only thing that I did not include in the Birth and Death Registration Act is regarding stillbirths. Now, stillbirth simply also says to say, if you as a practitioner, you were present during the delivery of a stillborn, you have satisfied yourself from the definition of what a stillborn is, you can certify that death. And it also empowers the professional nurses that are registered to also do that, those who were present during that. But it also empowers the medical practitioners as well, where you were not present and the stillborn has happened, you can also do that. I just did not include it here. But this 3 is exactly what I said. If you are treating a patient, you have reason to believe. If you did not treat, but you have examined the corpse and you are satisfied from the information, you issue that. If you are not satisfied that this is not due to natural causes, you have a duty to report or a duty to consult a forensic pathologist. I'm emphasizing this because often you do have cases that are on a gray zone area where you want that consultation before you can make a decision. And it's important to always consult with your local forensic pathologist in your province, in your region, in your district, in your area, to make sure that when you make a decision in those cases that are not clear, then you have that backup and you can even document in terms of evidence to show that you did consult and the discussion and the advice was exactly that. Now, this is the one, the Inquest Act, that says duty to report. And you will see that is an outdated act, if I may say, but 1959, you can see that because it still talks about district session and all other things. But it simply says, if you have a reason to believe person did not die of natural causes, you have got your duty to report. That's exactly what it says. And it further says, the investigation of circumstances of certain death. Any policeman who has a reason to believe after you have notified or reported that any person has died and that such a person has died from other than natural causes shall investigate the death or alleged death and report or cause to be reported the death to the magistrate of the district concerned. That's as it is what it says now. It further says, if the body of that person who has allegedly died is available. Now, the reason why it says is available is because you do have cases whereby we lost track or we did not apply those definitions that I gave you, and we misclassify and we certify it as natural, and yet that death is unnatural. The body in that case is not available. There will be another process. But in this particular case, when a body is available, the police officer will make those necessary arrangements that the body must be examined by a forensic pathologist or a forensic medical practitioner, if I may say. I'm using that terminology because the district surgeon is then when it was. Then, if the medical practitioner, forensic pathology medical practitioner particularly, and because that is an authorized person to do that examination on behalf of the police and the magistrate in question. If that medical practitioner deems it necessary for the purpose of ascertaining with greater certainty the cause of death, make or cause to be made an examination of an internal organ or any part or any of the contents of the body or of any other substance or thing. Now, this act empowers the forensic pathology medical practitioner to exercise exactly what I indicated earlier on. Collection of tissue samples for microscopy examination, collection of whatever fluids for toxicology analysis, even collection of the entire organ for further examination, to fix the brain for later neuropathological examination, or even fix the heart for further cardiac pathology examination, because you do have situations where we want to examine the conduction system, and that's exactly the reason why it says that. Now, I have already taken you through this unnatural death. Now, this is the act that I wanted to highlight in terms of the section 48 of that amendment. This is what the act used to say. That's why I put it in red. It's not what it says currently. I'll take you to what it says currently, because this is where a lot of confusion is arising from practitioners to say the death of a person whilst under the influence of general anesthesia or local anesthesia. It talks about anesthesia only here. But we all know that a person who undergoes a surgical procedure for either diagnostic or therapeutic or palliation, it is not only the anesthesia that is at play. Hence, this act was amended to this one. This is what is currently applying or guiding all of us as practitioners to say a death of a person undergoing or as a result of procedure of therapeutic, diagnostic, or palliative nature, or of which any aspect of such a procedure has been contributory cause, shall not be deemed to be death from natural causes. This was amended to exactly correct what was previously in there. There were good intentions, However, I'll highlight something to all of you. There were good intentions to ensure that if I take a pregnant woman to theater for a cesarean section and I accidentally put the tube into the esophagus, and that patient subsequently suffers hypoxic brain injury and stays in the hospital for weeks and months. This says that that death must be investigated. Previously, I know there was a practice to say timelines, if it is after a certain period, therefore. Now, that was not justice for the families, for an example. Another situation is where you take a patient to theater and then you sever a uterine artery, for an example. Patient bleeds and bleeds and bleeds. Then the patient ultimately recovers from the anesthesia, but the patient ends in ICU, suffers from the complications of the blood loss from the severed uterine artery. The patient subsequently succumbs to that. So it was taking away that investigation aspect to determine whether the physical procedure caused or contributed to the death of the deceased. And also, it says to you as a general surgeon or a surgeon or an anesthesiologist or a practitioner who's involved in this, it says, do not become a player and a referee. It says this death must be investigated, it must follow the Inquest Act, and an inquest must be had. However, there are lots of challenges here, a lot of practical challenges, and for everybody, if I may say, both for the practitioners, treating practitioners, for the families, and for the forensic pathologists. So I'm saying that just to highlight one of the pitfalls of this act, but this is what it says in its current form. It is not only anesthesia, but it's the entire procedure of diagnostic, palliative. Because if you take a patient to radiology, for an example, you administer a drug for the purpose of image modality or images that you want to subject the patient to, but the patient reacts to that. That death cannot be certified as natural. Just giving that as an example again. Now, I'm going to quickly run for the completion of death notification form. Having considered the legislations, having considered the definitions, now you have a patient who, unfortunately, who was precious to all of you as a treating team or as a doctor. We need to be careful, because if a patient dies, it is just, we tend to say it's just one more hospital death for us as healthcare practitioners. But for the unfortunate family, it's a permanent loss. And that is a quote from Sudan Matri. Now, the implications of a death of your patient, the permanent loss for the family members, and our decisions what to do when a patient dies has got implications for these families. And I'll take you through to say, why do we complete this form? It's a legal document, like I've mentioned. In South Africa, in the Republic of South Africa, the laws are clear. When you're born, you get registered. When you die, you get registered, because it's a permanent record of the fact of death. Because we know there are situations where someone is said to be alive, but the person is actually has demised. It's information about the deceased person. It's information that allows the Department of Home Affairs to issue a death certificate and a burial order. Again, when I say your responsibility does not end when a patient dies, it is for this family to be able to get this death certificate, to be able to proceed with the burial preparations. In our culture, in our society, and it applies to everybody. When a person dies, we need to start preparing, we pack up, so that we can bury the person in a dignified manner. Now, without this, that cannot happen in most in our situation. Now, number 4 is very important. It's the information that may be used to settle deceased estate, application for insurance benefits, pension claim statement, settlements. I give an example here. If you don't observe those definitions that I gave, someone falls from a moving vehicle at work, succumbs trauma to the head, gets admitted to the hospital. 4-6 weeks later, person dies. And during that stay, obviously, nosocomial infections, they took place end. If you certify that death as natural and is registered as natural, the family takes the certificate because they want to bury. 6 weeks, 6 months down the line, they go to workmen's compensation processes, insurance benefits, because there are 6 dependents that this person was a breadwinner in the family, and also extended family members for that matter. Now, African culture, you find yourself taking care of a lot of people in your family. Now, this natural certificate or natural causes of death certificate, there will not be this pension, this payouts as the circumstances were of unnatural cause, but you are giving the natural cause. Now you can tell the implications of not observing that. It's got implications. Now, of importance here is for planning purposes by government, public health agencies, for an example, to track the goal, the Millennium Development Goals, such as maternal mortality ratio, under 5 mortality ratio, and other state agencies to use the data that we put on this for prevention and for intervention where there is a public health concern. Now, it's very important that we complete this accurately and also for research purposes and allocation of resources and prevent morbidity and mortality. Now, these are the components that I'm not going to dwell much into, because this form, the DHA 1663, has got a section A that talks to who died, because this person was born, now this is the person who died. That information must be accurate and complete. And as practitioners, we need to ensure, because it has happened that a colleague was actually arrested for completing a form that had incorrect person who was registered as dead. And it's up to us to make sure that information is correct. There's a section for medical practitioner, which is the one I'm going to show you quickly. There's an informant particulars or undertaker's details. And there's also administrative section of that form. I am zooming onto this particular section because this is where most of us are involved, and I want to make it clear to say that this is where you complete your details and you are certifying to say you are satisfied that this person has died of natural causes. But I also want to advise that when you look at 22.1, there, the 2 boxes, I would advise that if you have a reason to believe the person did not die of natural causes, do not even complete this form. Just follow the inquiries, because once you tick here, there's confusions that we have realized that mortuary attendants and whatsoever in a hospital setting, they may say, oh, the doctor has completed this form, and they release the body, unfortunately, only to realize later that no, it's not supposed to be released. But of importance, this form, you sign the form and you say, I, the undersigned, hereby certify that I have examined the body of the deceased, named in section A that I've just mentioned, and declare that the deceased, to the best of my knowledge and belief, solely died and exclusively due to natural or unnatural, because this is the one I'm talking about, to say, please don't even do that if you have a reason to believe. But if you were satisfied this natural, and in case this is not true, I shall be guilty of an offense and on conviction liable to a fine or imprisonment for a period not exceeding 5 years. This is how the form is. It's from Home Affairs, and we sign accordingly. So I want us to observe this part on the basis of the definitions that I gave to say that. Now, who must complete, or who can complete? A registered medical practitioner. And I know there's always a question of, can interns complete? Yes, interns for that purpose are allowed to do that. However, under strict supervision, they must not complete this form on their own without consultation. A registered professional nurse, like I've mentioned, for stillbirths. A traditional leader in some of the rural areas, this is still a practice if there's no doctor available, but they use form 1680. That Form 1680 is just to say that the family says this person was sick, because they are not experts, they are not healthcare practitioners, but they are still allowed by law to complete this. Then Home Affairs will translate to that. Now, other role players are undertakers, informants, and Home Affairs officials. Now, the procedure-related death, I'm just going to quickly take you through this, just to say that this is a category of death that is always a bit of a problem for all of us. But these are the deaths that are occurring due to or after surgical operation, invasive diagnostic procedure. Of importance, what I've mentioned, the time interval post-administration of anesthetic agent is not of relevance. It is all about the causal link. So I need us to be clear on this, because colleagues that are still saying, no, but it's after so many hours, it's after so many days. It is no more relevant according to the act that has been amended. How are they classified? These are the deaths that can be directly caused by the disease or injury for which the invasive procedure or anesthesia was being performed. So the person comes in a grave condition to the hospital. You do your best in terms of trying to save, but they still succumb to that disease or injury. But there are those that are caused by a disease other than that for which the procedure was being performed. Person had an underlying undiagnosed condition that unfortunately he or she succumbs to. That was undiagnosed. The person was not being operated for that condition, but it's discovered that, no, he actually had an underlying atheromatous condition within the coronaries that was undiagnosed. Classification, there are those that are resulting from complications of the invasive procedure. Like I've indicated, patient goes to theater, either liver is being severed or whatever major structure, and the patient subsequently loses blood, or they succumb to the complications of that invasive procedure. And you will have those deaths that are as a result of administration of an anesthetic agent, either the general anesthesia or the local anesthesia, such as high spinal. Now, what are the steps for you as a practitioner to follow when you have this? Because this is a big issue for all practitioners, particularly the whole team of practitioners who are involved in the management of a patient. The role of a medical practitioner is to certify the death, basically, confirm the death, obvious, but you must ensure that medical surgical apparatus are not removed. Keep them there. Do not complete. Like I've mentioned there, the best advice that I give, although it does allow you to certify, do not complete the DHA 1663. To avoid confusion, you've got a duty to report this death. Of importance, consultation with forensic pathologist is important, because we will be able to discuss and advise accordingly, because that act, like I said, is broad enough. So there are certain cases where we can interact and give information. You need to complete required information. I know I put D28 and G7W24. This is originally termed, but in certain areas they are called FPS number, and. But these are the forms basically where you put your medical information, the medical history, what you did, what the patient was, how the patient was, the investigations that you conducted, and the GW724 is basically the one when you took the patient to theater. It's completed by all role players, anesthetist complete, the general surgeon completes, including the nursing team, they complete as additional team members. Importantly, ensure accessibility to hospital records, because we require this for the purpose of post-mortem examination. And the delay, which is what I'm going to highlight to say common challenges, the delay actually affects the families if we don't observe this. And these are the common challenges that I'm talking about. Delay in reporting. A patient dies on Thursday or Friday, medical practitioner does not report. Come Monday, Tuesday, inquest case is not yet opened. By Wednesday is only when the body comes to forensic pathology services after the inquest has been opened and the completion of documents have finally been completed. But the body comes and finds forensic pathology services having 35 bodies for that week. Now, that family will not bury. They will bury because they join the flow of work because of the dynamics in the forensic pathology services. The other common challenge is the communication-related challenge. As healthcare practitioners, when the patient dies, immediately we then phone the family and say, your loved person has died, please come. The families, they call their undertaker because we are not explaining to them that this is a process that must unfold and we need to observe that before we can commit to a burial. These are some of the common issues, and families, they commit financially. Most of the time, we are dealing with poor families. They commit financially. We did not give them information. They start preparing for burial. Come Wednesday, Thursday, postmortem is not done. Postmortem is scheduled for next week, Wednesday. And the family cannot bury. They have committed financial with the little funds. Now, another one is the misclassification of deaths. And that is exactly what I was saying. If we don't certify accordingly and classify and report accordingly, that is a common challenge. I've put this, but I think colleagues can read it perhaps at their own time. I'm just looking at the time, but it talks about a patient who was operated and a hip replacement operation a couple of weeks ago and being immobile, and then subsequently a week later discharged from hospital, deep vein thrombosis is diagnosed. 2 days later, patient was found dead in a bed. And obviously, GP considered the cause of death to be pulmonary embolism, but they certified the death as natural. And you are attending a funeral yourself, and to say that given the history and all that, you have a nagging concern that given the recent procedure, the death was probably procedure related, but you are at the funeral. Are you right? And what are your obligations as a healthcare practitioner? Now, there is another quote from a colleague, quite a son, who was recently asked to advise what private sector doctors should do when families of deceased patients refuse to give consent to medical legal autopsies or to sign affidavits stating that they do not want the medical legal postmortem to be done. The matter is further aggravated when families become aggressive towards us as forensic pathologists who are required to conduct autopsies and demand that the body must be handed over to them. This is a common problem that you are facing, that I'm facing as well, where families say, we know this person was sick, why must we follow this process? Now it's upon us as practitioners to take them through the laws of the country. In most cases, when you do that, families, they do understand that it's a legal process. It's in the interest of both families and both the hospital or treating practitioners. However, should they require that, remember, they are free to approach the courts and order you to not to proceed with that. But the courts will obviously follow what the statutes are saying. Now, some of the common mistakes, I thought I'll just take you through quickly some of the common mistakes that we make as practitioners when it comes to the cause of death statement. We always put the cause of death statement at the end, that A, B, C, D, using illegible handwriting. Remember that last page is for what I said, why are we completing the death notification form? It goes to Stats SA for capturing, and the ICD-10 code, I think even 11 now, code it accordingly. Now, if it's illegible handwriting and a person cannot see, it goes to junk. We call it rubbish. It's unspecified, therefore we will not have an accurate picture of what is happening in your environment in terms of why are people dying. We must not use abbreviations because they are also junk. Nobody will be able to quote that. The other common problem is to reverse the order of immediate, intermediate, and underlying, like I have described earlier on. Intermediate is those biochemical derangements that are in between the underlying cause and the immediate cause. Remember, the underlying cause, the primary cause, is A, B, C, is at the end, it's D, because that's when you look at that form, it says A due to B, due to C, due to D. We cite mechanistic terminal events. I've mentioned that we cannot put mechanism of death and leave it alone without the underlying cause. That is the problem, which I'm going to show you some examples here. Non-specific problems, like I said, I'm going to show you this. It is acceptable to put, but you must substantiate or support them with what is the underlying or primary cause. The loss, we normally lose a track of events, like I said earlier on. The person sustained this, but 3 months, 4 months later, we forget that, by the way, this person came because of multiple sclerosis, but they developed a nosocomial infection. Incomplete socio-demographic data, it also does not give those that are supposed to intervene correct data. And for getting injured or poison, like I said, loss of track of events. Often, what is required at the end there is you must be specific as possible when you list. I'm not going to take you through the specifics there, but when you've got detailed information, for an example of a lung cancer that you've got histology, you put a poorly differentiated adenocarcinoma of the lung rather than just lung cancer. But if you don't have, obviously you will put unspecified, but it's a lung. You are saying you are still waking this patient up. Now, this is one of the common mistakes that we make. We just put septicemia, and I've indicated septicemia can be from natural or from unnatural. But as practitioners, this is what we commonly do. We just put it and leave it there. Then you put renal failure and put diabetes. Diabetes can be insipidus, can be mellitus, but how does it relate to the renal failure? That is the thing, because you remember I said A is due to B, due to C, due to D. Then we put internal bleeding. Internal bleeding can be from unnatural or natural, and we leave it like this. Instead of putting internal bleeding from a ruptured, perforated ulcer or whatsoever as a natural disease process, or internal bleeding from a blunt force trauma to the chest. So it's what we need to avoid. Cardiorespiratory arrest, a very popular cause of death in our country. Not only in our country, by the way, this is a global problem. It's still there in practitioners globally. We do that. We must refrain from doing that. Cardiorespiratory arrest must be due to what? Again, we list everything, but they may not make sense even to you as a practitioner. You see here, the practitioner wrote overwhelming sepsis from acute gastroenteritis, morbid obesity. Is acute gastroenteritis from morbid obesity? Is morbid obesity from hypertension? It's just a mix-up of things there. I thought I'll just close up with this case example so that we can see some of the implications. Now, this is a case that happened somewhere in Gauteng, the first one there. A male was stabbed and was taken to a central hospital for that matter. Through the eye, the sharp object went through the craniform plate and perforated or penetrated the brain tissue. And obviously, it's a neurosurgical intervention. Prolonged stay in the hospital with a pulmonary infection that was diagnosed, unfortunately died, and a medical registrar, not even not even a ComServe or a medical officer, a medical registrar certified death as natural. Now, the family in this particular case, they did raise a concern at the time before the body was released. And they raised a concern with the most senior person in that department, who reassured them, no, it will be done, it will be done. But the doctor already certified natural, the body was released. Family said, okay, they proceeded to bury. But the father of the deceased kept on saying, no, but this case went back to the police. Fast forward, we had to conduct exhumation because that body was coming from one province to the other. Exhumation order was granted because it's a murder case that was being investigated. Now, unfortunately, the medical registrar and some of the team members were also implicated to say, why did they do this? Are they conniving with the assailant? Now, these are some of the implications. Another one is an MVA, multiple injuries, prolonged hospital stay somewhere in Limpopo. The patient dies ultimately after weeks. The medical officer, who's a senior person as well in that section, certified that death as natural. Fortunately, this one was not buried. Then it was a prolonged process. The body had to come back from the private undertaker. They already released the body. But you can tell the delay because now they realize on Thursday before the burial on Saturday that this is what needs to happen. Everybody has to run. Department was taken to task. The third case here, a young guy, death on arrival, was rushed to casualty in one of the district hospitals and presented to casualty. Unfortunately, it was death on arrival, but they gave the medical officer the history that this person was using drugs. But the medical officer released the body. But the family also then, because of not understanding the processes or so, they proceeded to get a traditional leader to give them, because they wanted to bury. But someone in the family said, no, but this cannot. But they proceeded to bury. After a week or two, they went to High Court and obtained an order against the MEC to say, SAPS, you must exhume, MEC of Health, you must conduct a postmortem within 12 hours of exhumation, and the body must be reinterred within 12 hours of postmortem examination. Now, we had to conduct that postmortem examination because of that misclassification, particularly because the history was available. Colleagues, and this brings me to the end of my talk. I apologize. I think I went beyond some few minutes of the time, and it brings me to the end. And these are some of my reference list, and this is the end. And thank you very much, colleagues, for your time and for your attention. Dr. Kinoshi, I'm handing back to you.
Thank you very much, Dr. Mamashela. I see a lot of applause across the screen and thumbs up. I think this was amazing. Don't worry about the time. We are still losing. I see the score is 1-0. You can catch up. I think the second half.
You shouldn't have told me.
No, the second half has just started. There's still a lot of time.
Okay.
So yeah, we'll just go through a few questions that you have. But I think this was, in fact, a very informative lecture. Thank you very much. A refresher to some new facts to a lot of us, a lot of people. I think I've run out of adjectives: lucid, erudite, eloquent, enlightening. I think it's a lecture not to be missed, even on a day like this one. Thank you very much. But I'll leave the thanking to someone else at the end. For now, I think let's attend to questions that put in the chat box. If you would like to put your question or comment orally, you can just use your electronic hand, and then we will recognize it. You can then unmute yourself and ask your question, and Dr. Mamashela will attend to your questions or comment. But let's start with I think it's Dr. Leslie Ramia. He says, if one has a step heart, there's a patient with a step heart, I suppose, should we say as immediate cause is step heart, or should we say cardiogenic shock, or we should say step heart and contributory cardiogenic shock? How do you say? What is your guidance, Doctor, to a question like that from Dr.
Number one is
Ramia?
that if my colleague there who's asking a question is a medical practitioner and not a forensic pathologist, they must report the death. That's number one. But in terms of formulation, in terms of what I've described, the sharp force trauma for the test will be your underlying. The hypovolemic shock from the hemorrhage that ensued from the sharp force trauma or step to the heart that led to the blood loss will be your immediate cause. That is, will be your hypovolemic shock. But it will be coming from excessive blood loss, for an example, or hemorrhage. And then the underlying cause will be that sharp force trauma to the heart. That is the step to the heart. I hope it's clear. But the main thing here, if you are not a forensic pathologist, don't even attempt to complete the DHA 1663 in that particular case. But the sequence will be in that way. Yes. Thank you.
I think that's good advice, Doctor. Thank you very much. I think there's just this one. Let me just deal with this one. Dr. Fatima Vahed is asking whether the CPD points that they'll be receiving from HPCSA, whether these are ethics points or whether these will be general, he calls them general CPD points, the clinical points. I think this is an ethics lecture. If you've registered and you've put in your HPCSA registration number, HPCSA will automatically credit you with ethics points once you've attended this lecture. Just to clear that one. But let's go to I think with Dr. Rami again. When completing the DAH and following a physical exam, no postmortem, but history and interview, how can we exclude, say, poisoning without autopsy and toxicology? So when you conclude this Home Affairs form 163 and following a physical exam with no this thing, but history and but just history and interview, how can we exclude poisoning without autopsy and toxicology? I suppose if you've got a suspicion that you need to do this, then you refer to the forensic pathologist, or you ask for advice.
So it goes
Dr.
to
Mamashela, what would you say to that?
it goes to the acts that I've mentioned. Once you have a reason to believe that there's a suspected poison, you don't even complete, you report. Because you are the one. When you are taking history, there are pointers that say, hey, this person we suspect. However, I think the colleague is asking a great question, because the how can we confirm is about your history taking. Did you exhaust your history taking from whoever was giving you the information? Because it's not a routine practice. The toxicology will have to follow the inquest route to exclude poisons. It must have been reported. So that's why the Birth and Death Registration Act says to you that take history, satisfy yourself as a medical practitioner, examine the body, then it authorizes you to complete the death notification form. But if there's a history, and sometimes remember, colleagues, this history can also come 6 months later to say, no, we suspect that that person was actually poisoned. As a medical practitioner, at that point in time, when you completed the form, you completed it on the basis of available information and you took all reasonable steps. You will not be found wanting, but the new information is allowed. The law allows available new information, makes police to make a decision to investigate up to exhumation. We have seen those kind of cases where families come later to say, no, we suspect. And when the courts are satisfied as well that there's a reason for them to investigate and ascertain the cause, they will grant the order, and then we will continue the examination accordingly. So in a nutshell, toxicology examinations are not routine for everybody who dies, but it's pointed or advised by the history taking. Thanks, Doc.
Yeah, just as a follow-up, if the doctor after 6 months, as you say, or whatever, gets information that that patient whom he or she completed a notification of death as a natural cause of death, but then gets information that this might not be natural, the doctor has got a duty to report that, as, even if it's some time after the burial. Am I right?
Right. If that information surfaces anybody, it does not have to be the doctor.
Yeah.
Any member of the public who believes and have got facts, they must present themselves to the police and report, including the doctor, because you are now saying there's this information that is coming. So the Inquest Act says you've got a duty to report.
Yeah.
Yep.
Yeah. Okay. Thanks, Doc. And as we have Professor Derek Duplessis. Professor Duplessis is a cardiothoracic surgeon, by the way. He says by far most deaths are unexpected, in inverted commas, and we had on roughly statistics saying about 550,000 to about 600,000 in 2025 of such unexpected deaths. That would imply that 400,000 plus forensic investigations must be done every year. And he sees this as a big problem. Of course, I think it is because of capacity. You know, how many forensic pathologists do we have in the country, in government service especially? But he says also that, you know, with police investigations taking years, I think this is a big problem. So there's overload of these unexpected deaths. Dr. Mamashela, you want to comment on Professor du Plessis' question?
There are two aspects to the comment by Prof. And actually, thanks, Prof, for that comment, because what Prof is raising, it reflects on us as well as practitioners, because that data, remember, that comes and as it's actually the category that I mentioned, that it goes to the rubbish bin or junk status. So you don't have a true reflection of the cause of deaths because of what we write on our death notification forms. And they end up in that category to say that we've got this number that actually we are not sure of what actually happened because of what we've put. The coders at Stats SA, they code accordingly. If it's not codable, it goes to the junk and it then inflates that data. So if we improve on our cause of death registration process or notification, that number, I can tell you, it will come down. But the second fact that you are raising, Doc, is actually a reality. The capacity issues will remain a big problem. And I'll give you an example in terms of the provincial picture of forensic pathologists. You have provinces that are actually under severe pressure and they've got a high burden of non-communicable diseases such as trauma, interpersonal violence, such as Eastern Cape. It's a reality, what is happening on the ground. And you've got only 2 forensic pathologists in that province that can only do that much. So it's also an indictment on all of us to start looking at some of these administrative aspects to improve our systems, all of us. But yes, it's a reality that those cases that Prof is raising, most of them, one, they are unclassified. They are not specific. They can't be coded. Stats SA does not then give accurate data. Hence, we emphasize on training of this cause of death. And colleagues must take opportunities that are available, that are made available by the South African Medical Research Council, for an example, to embark on those online training courses, because it improves how you approach this and improves the quality of our data.
Yeah, thanks. I see Professor Christina Lundgren has got her hand up. Prof, you can unmute yourself and ask your question or comment, please.
Thanks, Dr. Kinoshi. Dr. Mamashela, that was a superb lecture. I'm an anesthesiologist, and my PhD was on anesthetic-related deaths. And so I've always had a huge interest in it. But I see there were a couple of anesthetic questions, and somebody still asks about the 24 hours. And that the 24 hours was never law. It was Harrison, Gay Harrison, in his review of over 30 years at Fortescue, used it, and he says he used it as an arbitrary cut-off because they couldn't follow the patients up longer than that practically. So, I mean, I wish people never ever said anything about the time. But what I wanted to ask you is one of the questions, I think Chris Kasha asked it in the chat, that's always very, very difficult in the state sector is when a patient dies on the table, do you leave all the tubes and drips and pipes in? And, you know, if they don't put the patient in a body bag, I mean, I worked at Barra for 30 odd years. If they don't put the patient in a body bag, who's to say the tube doesn't slip out, the porter pushes it back in, and who knows where it lands up? So, I mean, how do you feel about leaving the tubes and drips and everything in? And then my other question was, I got an email last week, quite an interesting question. A medical officer had completed a B1663 form and had made a mistake. And now the family was trying to claim on insurance. Can one cross that form out and redo the form was the question. So, you know, you can't alter that form as it is, but can you then say, sorry, I've made a mistake under oath with an, sworn affidavit or whatever, and then redo the form is my question, because I think it's quite important for
Maybe let's start with the
whether they
second
can.
question,
Yeah.
Prof. That second question, I think it will depend on what is the mistake from. Is it natural in state of unnatural or
No,
unnatural?
it was a date. It was a date of when some illness had started. And so, I mean, it was a genuine mistake, and it affected the insurance payout. So, no, it wasn't natural versus unnatural. No, not at all. It
So it
was a
was a
natural
natural.
death. Yeah, but the person had genuinely made a mistake. So,
Correct.
what do you do under those circumstances?
Yeah, so this type of errors, they do happen, colleagues. And the important part is that, remember, Home Affairs are one of the key stakeholders in this process. It may be important to also consult with Home Affairs that is relevant or responsible where the family is going to take for advice. Because yes, you can go and make a sworn affidavit to say, I so and so did so and so, and I'm completing the new one, and attach the old one with the certificate and request for correction, because it's a process that we follow when the death was originally certified as natural, and now the body is with us as forensic pathology, and we now classify it as unnatural, like the case that I've mentioned of exhumation. We then make a covering letter to Home Affairs. Is normally amended at national office. They do send it, but the turnaround is not bad. It's quite good turnaround. You made that submission. It must be a formal submission. You attach the mistaken one, and you attach the new one to say that, by the way, the person is deceased and you are trying to correct the mistake. But most importantly, consult that Home Affairs that is going to be helping you to correct that mistake, because it's a genuine mistake. So I think it's better to do it that way. The first question, Prof, the body bag, our standard practice as forensic pathology services is that all bodies must be in a body bag. And that is the reason why, to contain whatever evidence that is there. And hence, the preservation of whatever tubes, whatever pipes will then be contained in the body bag. I think
But
it
the
is
reality.
correct. I think the reality is it's another matter. But you can only do that much to try and preserve what you can preserve. And for an example, the ET tube must just be in the trachea, remain there. IV lines must just be there. I think there's a way that normally the nursing team will put them together there. They are still in situ, because we need to document that for the purpose of investigation, also to demonstrate your efforts in terms of what you did. Yes, if something falls off, it will fall off in the body bag. You would have left everything. So we always advocate practitioners leave everything in situ, particularly where possible. I know there are big machines that we cannot say bring the body with, but it will be documented. But thanks for that, Prof.
Thanks.
All right, thank you very much. I think we've got quite a number of questions in the chat box, so maybe we'll go faster. I see a hand from Dr. Tefo, but before that, let me take this one, because some of them have been waiting long, Doc. This is Dr. Belata, can an ordinary doctor, I suppose he means a GP or medical officer, ordinary doctor, I like the term, can an ordinary doctor do post-mortem investigations like a lumbar puncture LP, a blood test on a DOA, meaning on a death on arrival, who demised from natural cause? In other words, if a patient dies in casualty or on arrival in a hospital or in your surgery, and can you do LP? Can you take blood for testing, lab testing?
Well, if it's part of your diagnostic process that you want to ascertain, for an example, it's a minimally invasive process, but it will be important for the family in that particular case, because that patient has died, to be engaged, and also the issues of consent there, because why are you doing that? It's just like when you embark on a clinical autopsy approach. Because the clinical autopsy, it will be your full postmortem examination, but you would need to obtain the consent from the family to say, look, we need to ascertain because of what we are dealing with. So we would like to do this and that because this can confirm or rule out that. But I think in those kind of cases, it's always best to consult as well.
Yep. Let's go to Dr. Tefo, Dr. Ramadi Mechat Onika Tefo. Just your question quickly. You can just unmute yourself, please.
Good evening. Thank you, Dr. Mamashela, for a very informative presentation. So my question is just a bit of clarity. So in most cases, you find that in our clinical settings, when a patient demises, you find that they're being seen by a doctor that was on call the previous day. And when you come in the next day, you are expected to fill in the death notification form when the family has been called. So most of the time you find that you get there, you don't know the patient. You find that you don't know the patient because you did not see the patient or you did not admit the patient. You don't have much information on that patient. And when you look in the file, the patient is still being worked up. Like there's not much on the diagnosis of the patient. And the person who certified the patient dead on the previous night, find that they just wrote what they saw and then they certified it, and then the plan is to fill in the BI. So when you come in, what do you do in such instances? And my second question is just to ask if the death notification form allows any cancellation. For example, if maybe you fill in the patient's, the family member's details on the, like where you're supposed to fill in the disease details, are you allowed to just cancel and then just write legibly the correct information, or do you have to go through the next page or the next form? Thank you.
So the cancellation, it's a mistake that happens. So you'll have various options. If it's a gross mistake that involves a bigger section, for an example, it's a matter of completing a new one if you still have that opportunity to do so. But if it's a minor correction, remember, obviously, when you cancel, the process of cancellation and putting a new information is followed by you countersigning that area. But Home Affairs, they normally are the ones who are very sensitive about that. It may be safe to complete a new one to avoid the family moving back and forward. I think that would be my advice there. Now, the issue of a patient who was treated by a doctor, remember the Birth and Death Registration Act allows you to say, if you were not treating the patient, but you've got the clinical information when you are now on call, when you are taking over from your colleague, you can go through the file and you make a decision on that, whether it's going to be natural or not. Remember, it may be that sudden unexpected, like you are still waking up and there's nothing, but the history suggests sudden unexpectedness in nature. You follow the inquest route. But if there is something that you are all satisfied, your colleague who knocked off and you who are coming in, that is natural causes, you can complete that on the basis of the clinical information from your colleague that you have examined. And that is a general occurrence that happens in most cases in our hospitals, because you go and the other one comes, but the file must have that information. But it goes back again, the detailed recording of clinical information in our files, which is still a big problem amongst us as practitioners. Thank you for that.
Thank you very much, Doctor. We've got Professor Yasmin Adam. Professor Yasmin Adam is an obstetrician, senior academic obstetrician, Dr. Mamashela. Prof, your hand is up. You can unmute and make your comment or question, please.
Hi.
Adam.
Hi, good evening, and thank you so much for the lecture. My question is related to when we have a maternal death in an antenatal patient, and the family want us to deliver the fetus after the death. Are we allowed to do that? So sometimes they want the baby to be, buried separately. Thank
You
you.
are allowed. You are allowed because remember the families, they have their own cultural, religious practices, and we need to give consideration to such, because when they say they want to bury the child alongside in the same coffin with the mother, or they want to bury a child in their own coffin, obviously depending on issues of viability, but we need to afford them that opportunity to do that. But obviously they need to give you that consent of some sort for you to do that post-mortem, because you are talking about the mother who died and now they want the baby out. There must be something that authorizes you to do so, and a simple consent in writing from them that can go into your file. It is allowed. You can do that because in most cases in the hospital setting, for an example, in hospital mortuary side, the medical officers, they tend to assist families in that manner. It's not a police case. It's something that you consider, and they give you consent, and then you can do that. Thanks, Prof.
Thank you very much. We've got I don't think we'll be able to go through all the questions. There's so many, they keep on coming, Doc. But if maybe we can answer as much as possible for the next 4 minutes or so before we close. Those questions that we have not had time to attend to, we will keep them because we are recording this session. Tolakele in the background is assisting me record. And then we will send them to Dr. Mamashela, and he can attend to them and respond to you later in a few days' time. But let's take Dr. Makali Mutlante says it's a long story, but I think it's worth reading. He says a doctor completed the death form as natural, right? He did not visit the mortuary to examine the body. The patient was supposed to be cremated. To be cremated. The second doctor went to examine the patient and observed injuries on the body. He declared the death as unnatural. The son was a drug addict, killed his mom for inheritance. This was a white woman. I was wondering why he mentions that the patient was a white woman, but if you read further, you'll know why. He says this was a white woman who was brought to a township mortuary, which in itself became suspicious. Townships, usually it's us black people. So, and it is a white family so it became suspicious. The son was then arrested and sentenced. So he was found guilty and sentenced, convicted, I suppose. The doctors, so I think this is Dr. Mutlante's advice, doctors must always examine the body. Do not fall, I don't know what you wanted to say here, Doc. Do not follow the natural course. But I think the advice is clear. You must always examine the body, even if it is your patient. Go and examine them. Most of the doctors in the townships do not examine home deaths. The family comes to your surgery, your practice, and say so and so has passed on. It's your patient. You've got records of the patient. And then you write your notification of death based on your knowledge of the patient's clinical history, and without examining the body. So I think this is just a warning. Thanks, Dr. Mutlante. Any comments from you, Dr. Mamashela?
A very good advice.
Yeah.
Remember when I intentionally projected the section where you complete your MP number, your practice number, and you sign and declare. That's exactly what I meant to say. Once you declare that, once this investigation then takes place, that form comes and says, but you said that you are declaring that should I be found guilty or so, I can be charged. Because you declare that when you fill in that. So it's a very good advice for all medical practitioners that Dr. Mutlante is giving to say, let's examine. It takes you 5 minutes, colleagues, even less, to examine the body from head to toe and rule out whatever injuries that may be there. That's the least we can do.
Yeah,
but it's a very good advice here.
Dr. Jaffa, I think Dr. Tanwil Jaffa says, can a doctor insists on a postmortem even if their family refuses. This is for patients who are admitted in hospital, but no procedures have been done, and the death happened unexpectedly. What happens if a patient's family refuses a postmortem in such a case?
Oh, again, you go back to the definitions. If it's a natural process and you are satisfied, but you want to do an autopsy, that will be a clinical autopsy. You need consent from the family, and the family can say no. The family can
but
say
I think
yes.
in this case, he doesn't know whether it's natural or natural. It's a patient who's just arrived and just demises.
Correct.
Yeah.
So if it's classified under sudden unexpected, it's a police case. Remember that definition. It goes to the inquest. That's you've got a duty to report, and you explain to the family that you are not going to get the death notification form from us, and as a result, death certificate won't be available because of the legal requirement. I think it's as simple as that.
Yeah. I think this is from Dr. Rose Mutuba. He says, for deaths that occur outside the hospital facilities, that at home, is it within the law for doctors to charge for completion of the DHA form? In other words, that Home Affairs Form 163, just for filling the form for deaths that occurred elsewhere at home?
So I guess practitioners do their rates accordingly in terms of if they want to say, I'm charging for my time to come out and come to the mortuary and. And that is an arrangement normally with the funeral parlors and the doctors. But like I said, it can be for free. But in terms of legalities, I may not be able to say it's legal or illegal on that, because that's what normally GPs will charge for their time and the work that they do.
Yeah. I suppose in a case where you just fill the form, I think it will be risky for the doctor to charge, especially if it's been your patient all along and they tell you the patient demised.
Those are the things. Yes.
And all you have to do is just to fill a form. I mean, I don't know how you would want to charge unless you, of course, you had to go to the home and you had to go
I think that's what I'm saying. Those are some of the things that practitioners will say, my time, my visit to that and that. Those are the arguments. But again, the argument is exactly what you are saying. It's your patient, and how do you then relate?
Yeah. Dr. Ramia again says, undertakers are often using private doctors to complete DAH 163 forms. Often the deceased has other doctor as their GP. Is this ethical? I've heard about this as well, where what do you call them? Undertakers have got their own set. They've got their own set of doctors that they use where a patient had not gone to a doctor, for instance. I've heard this. Yes. I mean, I've had relatives asking me about this. The patient hasn't visited a doctor for the last 5 years, and suddenly demises, and then they find a doctor who signs this. Is this legal?
So that again, it goes to what the Act says, to say if you examine a body and you have not treated that person on the basis of available information, because you have many cases like that. People die, they have never visited a healthcare practitioner. But the key issue here is when you determine if this is natural or not on the basis of available information, then it allows you to do that. It goes to a similar example where the colleague asked, I did not see this patient, but there is this information. But in terms of those billings, I think those are some of the issues that practitioners, undertakers, and why are they charging? I think that is the key issue that can be taken as another discussion point.
Yeah.
But for a patient who was never seen by a practitioner for 5 years or 6 years, if it's not sudden unexpected, it follows that. But if it's a sudden unexpected, then it means you must report that case and avoid those kind of issues.
Yeah, I think I'm going to, and I must apologize for this curtail the questions. There are more and more coming, Doctor. But as I said, we will send them all to you. Tolakela is listening in the background so that you can attend to them, and then we will respond. We've got all the people who are attending here today. If you had got the Zoom link after registering yourself, you would be. We have your email address, so we'll we'll send them to Dr. Mamashela, and then we'll attend to them. I'll just take one question before I hand over to someone who's going to do the vote of thanks. Just this one, because I think it might be interesting. I've skipped quite a number. Some of them, repetitions of what you've already addressed in in answering other questions or in your presentation. Dr. Mpoma Chango says, how do you ensure confidentiality of the deceased in a case of RVD, HIV, I suppose, related cause that was never disclosed to the family? The family never knew that their loved one had HIV/AIDS. How do you have to disclose?
So there is one aspect that says when you die, you lose some rights. So your rights, you lose them. And one of them is exactly this, in terms of your role as a medical practitioner. Remember, the document itself, the last page, it's a confidential page. It is supposed to be sealed or put in an envelope, and only Stats SA will be the ones to have, not even Home Affairs has access to that form. It goes, Home Affairs, they take it, they pass it to Stats SA. It is for statistical purposes, meaning that as a practitioner, when you complete this form, you must ensure that the last page is sealed for confidentiality purposes. However, once you ensure that, and from the exit of your practice or the institution, when they leave and they decide to open it, that is for their own issues to account for. You would have ensured that it's sealed, because it's not for any, even insurance companies are not entitled to that last page. And I think the issue of HIV, colleagues, it used to be a thorny issue, because if you recall, the insurances used to actually decline. As a result, practitioners were actually shying from filling the human immunodeficiency viral infection as the underlying cause, because of that concern that the insurances will not pay. But in terms of information to the families, if remember the issue of confidentiality there, like I'm saying, when you die, some of the rights, you lose them. And the issue of HIV, I think it's well outlined in terms of when do you breach confidentiality. If, for an example, it's the husband of a wife who did not know, for an example, that the husband was positive, and you've got an ethical obligation as a practitioner to disclose some of these things, but following, obviously, why do you breach confidentiality? So it's going to boil down to that.
Thank you very much for that. I think I have arranged with Professor Lundgren, I think, who asked the question or made a comment earlier. Professor Lundgren is former head of anesthesiology in the VETS academic complex, including the teaching hospitals,
on charger. Apologies. Proceed, talk. I'm just putting this on charger. It's fine.
No, that's fine. That's fine. So she's a former head of anesthesiology, but she's currently the head of clinical governance at the VETS Donald Gordon Medical Center, the private hospital, VETS Donald Gordon. So she's the head of clinical governance. And she's also honorary professor in Steve Biko Center for Bioethics. So I've just asked Professor Lundgren to thank you, Dr. Mamashela. Over to you, Professor Lundgren.
Thanks, Dr. Kanoshi. I wanted to ask you why my hand was up was the replies that Dr. Mamashela gives to all those very interesting scenarios. Maybe they could be available for all the attendees, because some of them are fascinating questions. I mean, I don't come across them in anesthesiology, but they're very, very interesting questions, and maybe we can all have access to the answers. But Dr. Mamashela, soccer or no soccer, there were over 600 people who logged in and attended this phenomenal lecture. So clearly filling in the B1663 and D28s, etc., still took priority. And really, it was a superb lecture. It's a subject that's interested me for probably the last 20 years, but wow, it was, and some of your slides from, old paintings and old pictures were amazing. So it really was a fantastic lecture. So thank you so much. Thank you to Thakadu and the whole team for all their backup. And I see we sorted out the screen problems, etc., in the chat. And thank you all for attending and staying on for all the questions. But really, thank you, Dr. Mamashela. It was really, really invaluable, because, as you say, we all have to sign those forms at some stages of our lives. So yeah, Dr. Kinoshi, thank you so much, really.
Thank you very much, Prof. And I think it was amazing. I said to Dr. Mamashela that because of the football match, we'll probably reach about 200 or 250. We had a couple of
600.
At the top, there were 617 people who had logged in to your lecture, Dr. Mamashela. 617 attendees. It's amazing.
Phenomenal.
And
absolutely phenomenal.
just the good news that Bafana have equalized now. They got a penalty, so it's 1-1, and it's in. We're into injury time now. Let's hope they hold on to that draw if they don't win in the last 5 minutes of the game. But thank you very much. And thanks to my team in the background, Neo, Tolakele, and Sister Nesisa in the background. Thank you to you. I think good evening and good night to everyone. We'll meet again next week, Thursday at 6 p.m. for yet another of our sessions where our colleagues, our expert colleagues, share their knowledge with their colleagues in the medical field. Thank you very much and good evening.